हेलो। हाँ, हेलो। मैं अभी कहीं दूसरे जगह हूँ, क्लास चल रहा है मेरा। ठीक है। हाँ, मैं बाहर बाद में बात करता हूँ।
करो यार, शुरू करो प्लीज।
हेलो डॉक्टर लालन। सर
हाँ।
हमें शुरू करना है क्या? हमें शुरू करना है क्या?
हाँ जी।
हमें शुरू करना है क्या सर? डॉक्टर लालन आप शुरू कर दीजिए।
हाँ, मैं शुरू कर सर, शुरू कर दूँ?
हाँ हाँ,
इंट्रोड्यूस।
प्लीज। डॉक्टर ललन, शुरू करो।
हेलो। So good evening. At the outset, I would like to extend my sincere thanks to Anupam sir, President Dr. Alok Bandari sir, for having me here on this vibrant platform. And I would like to compliment and congratulate all of you for this wonderful initiative, forward thinking idea of guest lecture for the benefit of resident and practicing pediatrician. This program is being very well appreciated by all who have attended this. And in fact, Alok sir has accommodated all most of the leaders of across the India on this platform. So now coming to the topic for today, that is PPHN, and for which we have a very excellent teacher, Dr. Anup Thakur. And Dr. Anup is well known for all of us who are present here. And it is my pleasure of introducing Dr. Anu, MD Pediatrics, DNB Neonatology, Senior Consultant and Neonatologist at Sir Ganga Ram Hospital. He is a highly accomplished professional and having numerous achievement and award in the field of neonatology. He has been a DNB and fellow teacher, trainer of NRP, echocardiograph, and ultrasonography. He has more than 80 national and international publications to his credit. He has been author and reviewer of many books. So without further ado, may I ask Dr. Anup to start his presentation? And I would also request the participant to write down his question in the chat box. So Anup, over to you.
So, good evening, everyone. Thank you, Dr. Anupam Sachdev, sir. It's been a pleasure to be on this platform to present the topic. Dr. Lalan Bharti, sir, Dr. Alok Bhandari, sir, Dr. Bis, sir, and IAP Delhi. And I will just share my screen. So, just give me a few minutes. Okay. So, I hope my screen is visible. And
Yeah,
the topic for, yeah.
yeah, it's
So,
visible and you are audible also, Anup.
thank you, sir. So, the topic which has been assigned to me today is something which is very close to my heart. It's persistent pulmonary hypertension of newborn. And the beauty of such cases when they come to an ICU is that it can scare even a very experienced and astute neurologist. So, managing such patients, sometimes you feel like you are actually a pilot of a fighter jet plane which is crashing down, and you have to steer this plane to safety and make the baby survive, which is really challenging sometimes, especially in severe cases. At the same time, we are at a point that it is very difficult to choose amongst various options of therapy in persistent pulmonary hypertension. So we don't exactly know which allotrope is the best and what is the best way to go about this babies in terms of diagnosis and management. So sometimes as a practitioner, as a clinician, as a neonatologist, you feel that you are like those blind men who are trying to feel the different parts of an elephant and guess what it is. Someone says it's a wall, or someone feels the tail and says it's a rope. Someone feels the ear and says it's a fan. Someone feels the tusk and says it's a spear. And someone feels the trunk and says it's a snake. So we actually do not know exactly what is the complete picture. And it is very important to try to have a complete picture when you're trying to manage these patients. Now, the objective of today's presentation is to understand transition. So, what happens in utero and what happens ex utero? So, PPHN is all about understanding what has gone wrong in the fetal transition. So, on the basis of this, I will try to give you the concept of persistent pulmonary hypertension of newborn, what it is, what are the various causes that has been defined for PPHN, how do we assess the severity of PPHN? So are there some markers, some kind of calculations which can help us to know the severity of PPHN? Then how do we establish or suspect the diagnosis? So there are some clinical pointers which can give you a clue. And of course, we have to understand that functional echocardiography or echocardiography is the gold standard to clinch the diagnosis. And then I would go swiftly to the management part of PPHN, where I would discuss about the respiratory strategies to manage these patients, the choice of anotropes, in what condition, what anotropes you need to give, and we'll talk about the pulmonary vasodilators, which is the best pulmonary vasodilators to use, what are the other options which we have. So this is what I'm going to talk about today, and that will briefly take, I think, around 50 minutes to 1 hour. Now, first of all, we need to understand how the fetal circulation goes on and what happens during transition when the baby is born. So in utero, what happens? The fetus is in a state of relative hypoxia. So if you understand the fetal circulation, so what happens? The blood is oxygenated in the placenta, and from the placenta, the blood enters into the umbilical vein. The fetal umbilical vein PO2 is 32 to 35 millimeter of mercury. So this is an oxygenated blood. So still relative hypoxic, but this is already oxygenated. Now this blood that enters into the IVC, the inferior vena cava, and the oxygenated blood is preferentially shunted from the right atrium to the left atrium. So there is a shunt here called a patent foramen ovule. So the blood is shunted from the right atrium to the left atrium, and this blood is oxygenated. From the left atrium, it goes to the left ventricle, and from the left ventricle, it is pumped out through the aorta into the various parts of the body. And if we see in the aorta, the initial branches, they supply the brain, and therefore the brain gets relative blood, which has a higher PO2. Now, what about the right side? So some blood from the IVC will enter the right side, and the blood which drains the upper half of the fetus comes from the superior vena cava into the right atrium. So this blood is deoxygenated. This blood is pumped out into the right ventricle and into the pulmonary artery. The problem here is that the pulmonary vasculature has got very high resistance. In utero, the pulmonary vascular resistance is high. So only say 15 to 20% of the ventricular output is going to go into the lungs. So lung has poor blood flow. Now, there are various reasons to it. One is that we have more vasoconstrictors acting in the fetal vasculature, pulmonary vasculature, which keeps the pulmonary vessels constricted. So the resistance is high and blood flow is low. There are mechanical factors like the full fluid filled lung, and even the blood vessels. They have tubular endothelium, so they have increased vascular smooth muscles which constrict and give high resistance. So blood barely goes into the lungs. So what happens where this blood will go now? So what happens? The blood now from the pulmonary artery is shunted across, okay, through a duct called the ductus arteriosus into the aorta. So the lower part of the body receives blood which is slightly has a lower oxygen content, and the upper part of body receives blood which is slightly oxygen rich. So in the fetus, if we see what is happening, the pulmonary blood flow is less because of high pulmonary vascular resistance. And there are two shunts operating, two right to left shunts operating, one at the level of ductus arteriosus and other at the level of patent foramen ovale. This is what is happening in the fetus. What happens after birth? So once the baby is born, the transition should happen very quickly. So what happens? So when the cord is clamped, what happens? The systemic vascular resistance, it goes high. There is more systemic vascular resistance. There is increase in the blood pressure. So the direction of shunt will reverse across the across the ductus. So here it becomes left to right, and the shunting across the PFO will stop at birth. So there's no shunting here. Okay. So what happens now? The blood has to flow from the right atrium to the right ventricle across the pulmonary artery. So this shunt is now no longer operating. And more blood will go into the lungs. What about the pulmonary vascular resistance? So as soon as the baby starts to breathe, oxygen is a potent vasodilator, and there are other mediators which act on the pulmonary vasculatures, which decrease the pulmonary vascular resistance and increases pulmonary blood flow. So more blood will now flow into the lungs because the pulmonary blood flow increases because of decrease in pulmonary vascular resistance. So blood now flows across the lungs. So what happened if you see grossly, there were two shunts which are operating. The shunts have stopped operating and the direction here has changed. And the circulation, which was like in parallel, there were two shunts, have now gone into series. So blood is going into the right atrium, into the right ventricle, into the lung, then into the left atrium, left ventricle, and into the body. Okay. So this is what is happening at transition, when the transition is smooth. What is PPHN? So PPHN, or persistent pulmonary hypertension, is a condition where the pulmonary vascular resistance has not gone down. So there is high PVR, elevated pulmonary vascular resistance, just like the fetus. Okay. So what happens because of elevated pulmonary resistance? The blood from the right side is not able to go well into the lungs. Okay. So there is decrease in the pulmonary blood flow. If the blood is not able to go in the lung, then the oxygenation will decrease. So there is decrease in the oxygenation. Okay. And since the pulmonary vascular resistance is high and blood is not able to go into the lungs, what also happens is that there is, because of high pulmonary vascular resistance, there is right to left shunting of the blood across the PFO and across the. So basically what is happening in persistent pulmonary hypertension is that the physiology that was in the fetus is being continued in extra also. So fetus have pulmonary hypertension in utero. They have decreased PVR. When this persists even after birth, resulting in elevated pulmonary vascular resistance, decrease in the pulmonary blood flow, and right to left shunting of blood, then we call it as persistent pulmonary hypertension. And because of decreased pulmonary blood flow and right to left shunting of blood, there is decrease in the oxygenation and there could be a failure in oxygenation. Since the oxygenation depends on the ratio of PVR and SVR, how much is the vascular resistance and how much is the pulmonary resistance, therefore the oxygenation is labile. So if the pulmonary resistance is high, the oxygen will go down. If the pulmonary resistance becomes lower at some point of time, then the oxygenation will go up. So there is labile oxygenation. So this is one of the hallmarks of persistent pulmonary hypertension. The incidence is roughly 1 to 2 per 1,000 live births. And despite advances in various therapeutic options of persistent pulmonary hypertension, including nitric oxide in the 90s and ECMOs in the 80s, the mortality is still between 5 to 10%, even in countries which are well developed, and of course, higher in research persons. So if we understand, this is nothing but persistent fetal circulation because the fetal high PVR is persisting. So the older name was persistent pulmonary hypertension of newborn. Now people use the term persistent fetal circulation because pulmonary hypertension can also be acute or chronic and develop later. And recently, most of the hemodynamic experts across the world, they use an umbrella term to include all this, which is called hypoxic respiratory failure of newborn. Okay? So severe is the PPHN. It can lead to hypoxic respiratory failure and includes all these kind of conditions of course. Now, we need to also understand the concepts of chemical mediators that are operative in utero and after birth, because our therapeutic options are also going to act on these particular mediators. So this is the most simple one which I could pick up, the three pathways of mediation of vasoconstriction and vasodilatation. So in the endothelial cells of the pulmonary vasculature, we have the cyclooxygenase system. This cyclooxygenase system produces prostacyclins, and these prostacyclins, they through the cyclic AMP pathway, they lead to vasodilatation. Now, there is an enzyme called adenyl cyclase. So, if you activate this enzyme, adenyl cyclase, then what happens? There is increased production of cyclic AMP, and cyclic AMP it leads to vasodilatation. Okay? So, vasodilatation means it will decrease the pulmonary vascular resistance. The other pathway which is operative is through the guanyl cyclase, soluble guanyl cyclase pathway, which is the pathway for nitric oxide. So in the endothelium, we have certain cells that secrete nitric oxide. So there's an enzyme called nitric oxide synthetase, which produces nitric oxide in the cell. This is more so at birth, and this stimulates the enzyme called guanyl cyclase, which leads to increased production of cyclic GMP. Now, cyclic GMP and cyclic AMP, these are vasodilators. Okay. Now, if their concentration is decreased because of certain enzyme like phosphodiesterase inhibitor 5 and phosphodiesterase inhibitor 3, then cyclic AMP is converted because of phosphodiesterase enzyme into cyclic AMP. Similarly, cyclic GMP is converted by phosphodiesterase 5 enzyme to GMP, and then the vasodilatation will stop. So if we want to have more concentration of cyclic GMP and cyclic AMP, then we have to inhibit these two enzymes. The third pathway, which is operative, is the endothelial pathway. So from pre-proendothelium, proendothelin, endothelin A and B are secreted, of which endothelin A is a vasoconstrictor. So if you want to allow vasodilatation to happen, you will have to inhibit the endothelin A pathway. Okay. So if we see here prostacyclins, okay, prostacyclins, nitric oxide, okay, these endothelin A, okay, inhibition of endothelin B, inhibition of phosphodiesterase 5, inhibition of phosphodiesterase 3, these all will lead to vasodilatation and decrease the PPI. In the fetus, the chemical mediators which cause vasoconstriction are in a higher amount. So whether it is endothelin A or it is leukotrienes, whereas the chemical mediators which causes vasodilatation like nitric oxide, prostacyclins, these are lower in amount, therefore the pulmonary vasculature is high. At birth, if the chemical mediators do not get transitioned in a proper way, for example, the nitric oxide does not increase, the prostacyclins do not increase, then it could lead to persistent vasoconstriction and increase in the pulmonary vascular resistance. So what happens during transition is because of in utero, what is happening is that the vascular tone, the peripheral vascular tone, the pulmonary vascular tone is high, and there are mechanical factors like the compressed lung, the fluid in the lung, which leads to decreased pulmonary blood flow. The vasoconstrictors are in higher amount. The nitric oxide effect and the guanylate cyclase enzyme is in the lower amount. Okay? So therefore, there is increased PVR and there is increase in the pulmonary artery pressure. Okay? So the pulmonary artery pressure is high in the fetus. Now, at birth, what happens? As soon as the baby starts to breathe and take it oxygen, and the fluid in the lung is also replaced by air, oxygen is a potent vasodilator. An increased pulmonary flow itself in the lung induces the enzyme endothelial nitric oxide synthase, which leads to increase in the nitric oxide and improvement in the pulmonary blood flow. Also, there's increase in the prostacyclins adenyl cyclase enzyme, which leads to vasodilatation, pulmonary vasodilatation, and increase in the pulmonary blood flow. So what happened at birth? Rapidly, what happens? The systemic blood pressure, it goes high because of the clamping of the cord. The pulmonary blood flow, because of the effect of nitric oxide, oxygen, replacement of fluid in the lung by oxygen, and because of increased prostaglandin activity, the pulmonary blood flow starts to go high. Okay, the pulmonary blood flow improves. The blood now starts to flow in the lung and oxygenation improves. And there is fall in the pulmonary artery pressure gradually. If this transition is not happening proper, then the pulmonary artery pressure will remain high. The pulmonary blood flow will remain decreased, and this can lead to poor oxygenation. Okay, so if you look here, there is almost 6 to 8 times increase in the pulmonary blood flow, which happens in a matter of few minutes. So if this is not happening, it will lead to persistent pulmonary hypertension. So what are the various causes of persistent pulmonary hypertension? Okay. So persistent pulmonary hypertension can be idiopathic. That means you don't know the cause, okay, and these patients do not have any kind of lung disease. So here the persistent pulmonary hypertension is because of remodeling of pulmonary vasculature which has occurred in utero. Here the lungs will be clear, and this is also known as black lung persistent pulmonary hypertension. Then persistent pulmonary hypertension could be secondary to any parenchymal lung disease. So like it could be secondary to pneumonia, secondary to meconium aspiration syndrome, secondary to sepsis, or any other lung disease can lead to parenchymal disease can lead to increase in the pulmonary vascular resistance and cause PPHN. Then it could be because of abnormal transition. So something has gone wrong during transition. So if there is asphyxia, so the baby was not able to breathe properly. So if there is acidosis, there was hypoxemia, hypercarbia. So all these can lead to abnormal transition, and this could lead to persistent pulmonary hypertension. Another scenario could be a status of pulmonary hypoplasia. So pulmonary hypoplasia might be present in conditions like congenital diaphragmatic hernia or pulmonary malformations like a CPAM, or in a scenario where there has been a rupture of membrane in the early second trimester leading to oligohydramnios and pulmonary hypoplasia, or renal malformations resulting in pulmonary hypoplasia. So this could be one scenario because of various conditions where not even the lungs, even the pulmonary vasculature is not well developed, and it leads to persistent pulmonary hypertension. The last scenario could be a scenario of where there's pulmonary venous hypertension. So pulmonary venous hypertension can occur when the pulmonary vein is stenosed, or there is left-sided cardiac lesions like hyplastic left heart syndrome, mitral stenosis. This all will increase the pressure here in the pulmonary vein. This will be transmitted into the pulmonary capillaries, and this leads to PPHN. Okay. So these are the various causes of persistent pulmonary hypertension in newborn. 90% of them are secondary, 10% of them are idiopathic. Now let's take a case to understand how these patients do. So let's take a term baby who was 40 weeks at gestation and birth weight was 3400 gram. Baby was born to primary gravida mother, and emergency LSC has been performed because there was some scenario of fetal distress and there was meconium stain like a. Baby did not require resuscitation at birth, but the baby immediately had respiratory distress, which shifted to NICU on CPAP because of distress. And within a matter of first 26 hours of life, baby's oxygen needs were high, baby was having breathing difficulty, baby required intubation. And on intubation, now the FiO2 is 100%. So this is the common scenario where babies are referred to our institute with an FiO2 which is 100%. They are desaturating, they're not able to maintain oxygen. Now, at this oxygen requirement or in this condition, can we assess what is the severity of PPHN? So at this juncture, the baby is on SIV mode of ventilation. FiO2 is 100%. The mean airway pressure is around 12, which is required to maintain the oxygenation. And the blood gas shows a PO2 of 50 millimeter of mercury. So we can assess what is the severity of persistent pulmonary hypertension or what is the severity of hypoxic respiratory failure. So there are some markers which can help us to assess the severity. So the most common parameters which is used globally is the oxygenation index. This is very simple to calculate. So what you do, you take the FiO2, multiply it by mean airway pressure, and you divide it by the PaO2 obtained from the blood gas. Okay, so this gives you the oxygenation index. Higher is the OI, more severe is the disease. Okay. The next thing which you can calculate is the alveolar arterial oxygen gradient. So the gradient of oxygen in the alveoli and the artery. So in the artery, what is the gradient? What is the partial pressure of oxygen is basically by the arterial PaO2. And for the alveolar oxygen pressure, you need to multiply FiO2 into barometric pressure. So its sea level, it is 760 millimeter of mercury. And you subtract the water vapor pressure from it. So water vapor pressure is 47 millimeter of mercury. So 713 into the FiO2 minus PaCO2. So you subtract the CO2, divide by R. So R is the respiratory quotient. So it is between 0.8 to 1. You can take it as 1. So if you calculate this, then it will give you the gradient or the difference between the partial pressure of oxygen in the alveolus and in the artery, systemic arteries. So more higher is the gradient, higher is the severity of hypoxic respiratory failure. And the third is the PF ratio. So PF ratio is the ratio of partial pressure of oxygen in the arterial blood, PO2, divided by the required FiO2. So these are the three parameters which are used to assess the severity of hypoxic respiratory failure. Now, if based on oxygenation index, so if the OI is less than 15, it is mild hypoxic respiratory failure, moderate is between 15 to 25, severe is between more than 25, and very severe or critical is more than 40. Okay. So more than 40 is a condition where you have to recommend a therapy called ECMO. We'll talk about it. Based on PF ratio, so PF ratio is PO2 by FiO2 ratio. So higher is the FiO2, lower will be the PF ratio. So mild is between 200 to 300, moderate between 100 to 200, and severe less than 100. Based on alveolar arterial gradient, if this gradient is normally between 5 to 10 millimeter of mercury, higher is the gradient, more is the severity, and more than 600 millimeter of mercury is very severe hypoxic respiratory failure. So these are the parameters by which on the patient's bedside, you can know what is the severity of hypoxic respiratory failure in an objective way. So, how do you approach a patient who has persistent pulmonary hypertension or who is hypoxemic? So, first of all, there could be some clinical pointers, some pointers in the history. So, is there any history of asphyxia, abnormal transition, meconium stain liquor, fetal distress, or mother has taken some drugs which are serotonin reuptake inhibitor, or there is history of NSAIDs being taken by the mother, or the fetal echo has shown in utero closure of the ductus arteriosus, or there is history suggestive of congenital diaphragmatic hernia. So these all could be the pointers in the history. Usually they present shortly after birth. Okay. And the hallmark is that there is labile oxygenation. The oxygen, the saturation fluctuates rapidly because it is dependent on the SVR and the PVR. The hypoxemia is out of proportion. What it means, the baby is oxygen, SpO2 is very low, but the baby's distress is not that much severe. So hypoxemia is out of proportion to respiratory distress. Sometimes, if you're a very good clinician, you can appreciate a single second heart sound. And if you take the upper limb and the lower limb saturation, so if you put the pulse oximeter probe in the right upper limb and the lower limb, that is the preductal and the postductal, there will be a difference of 5 to 10% in the oxygen saturation in the SpO2. And if you do a arterial blood gas, preductal and postductal, the difference in the PaO2 will be more than 10 to 20 millimeter of mercury. So these are the findings. These are the history and examination which are suggestive of a hypoxemic neonate who has persistent pulmonary hypertension. So in this patient, you go sequentially, you rule out infection. So you do some tests to look at the sepsis screen and the blood culture, make sure the blood sugar or the serum electrolytes are sent there in the normal range. Now, hyperoxia test was a test which was done very frequently in the past when we were fellows. But with the echocardiogram, with available now, most of the people don't do this test. Here, you ventilate the baby and give the baby 100% oxygen. So if the PaO2 rises to more than 100, it could be PPHN. If it is less than or between 50 to 100, it could be a congenital cyanotic heart disease. So this test was done in the past. Then you should do a chest X-ray to look at the lung parenchyma. So is there any secondary disorder which is causing pulmonary hypertension, the presence of pneumonia, meconium aspiration, diaphragmatic hernia, all this could be picked up in a chest X-ray. And then you should do a bedside echocardiogram, which remains the gold standard to diagnose pulmonary artery hypertension. Now, what do you find in the X-ray? What are the various findings which you can find in the X-ray? So, in patients who have meconium aspiration syndrome, what happens because meconium acts like a ball valve kind of thing where the air will go in during inspiration but doesn't come out completely during expiration. There could be airway obstruction with gas trapping. So, these may seem as a hyperinflated lung. Then there is surfactant inactivation, and there is places of atelectasis, that is collapses, small collapses, alveolar collapses, which can give heterogeneous shadows across the lung. So this is an X-ray which is typical of meconium aspiration syndrome, hyperinflation with heterogeneous shadows across the lung. Then if PPHN is secondary to surfactant deficiency, in these conditions, the lung will appear to be of low volume. It is less aerated, and you can see sometimes white out kind of lung, bilateral lung, which is suggestive again of surfactant deficiency. I talked briefly about idiopathic PPHN, where the persistent pulmonary hypertension or pulmonary artery hypertension is because of the remodeling of the pulmonary vasculatures in utero. So here the lung parenchyma is normal and the lung appears to be black. Okay, so this is also called black lung persistent pulmonary hypertension. The lung is black here because of decreased pulmonary flow and no parenchymal disease. Then in babies who have suspected to have diaphragmatic hernia, either because of antenatal ultrasound or presentation at birth with respiratory distress, shifting of the heart sound, scaphoid abdomen, you should suspect diaphragmatic hernia. And here what happens because of defect in the diaphragm, you will find the bowel loops in the left lung and the heart is shifted towards the right side. In this condition, along with this mechanical problem, there is also bilateral lung hypoplasia. And this decreased vascular surface area, increased pulmonary artery muscularity, hypertrophy of the smooth muscles in the pulmonary vasculatures, leading to severe pulmonary artery hypertension. So these are some of the clues which you can pick up in the X-ray. Then to clinch the diagnosis, we need to do a echocardiogram. This is very important if you want to diagnose persistent pulmonary hypertension. Now, with functional echocardiography being propagated throughout the world, more and more neurologists and pediatricians are learning the skill of echocardiography to pick up pulmonary artery hypertension at the bedside in the NICU. So this is a gold standard to diagnose PPHN. So what happens normally? Normally, the blood flows from the right atrium to the right ventricle to the pulmonary artery, and then blood from the is oxygenated in the lung. It comes back to the left atrium to left ventricle, and then it is pumped out into the aorta. And there could be some left to right shunt in the initial, say, 24 to 48 hours. Now, in case of pulmonary artery hypertension, since the pressure here is increased, so blood is not able to flow properly from the right ventricle across the pulmonary artery to the lung. So because of increase in the resistance here, the shunt across the duct now becomes right to left. Okay. Further, what happens because of increased right ventricular systolic pressure, the pressure being transmitted into the right ventricle pressure becomes higher than the left ventricle. So normally the left ventricle pressure is higher than the right ventricle. So because of increase in the right ventricular pressure, the septum starts to now bulge towards the left ventricle. The septum bulges towards the left ventricle. So you can pick up this in echocardiography. You can pick up the shunt in echocardiography. Further, because of increasing the right ventricular systolic pressure, there is tricuspid regurgitation. So the blood regurgitates in across the tricuspid valve from the right ventricle to the right atrium, and tricuspid regurgitation could be picked up in echo. And if you measure the velocity of tricuspid regurgitation, then you can also calculate the pulmonary artery pressure. So if you know the velocity of tricuspid regurgitation, the velocity of blood which is jetting across the tricuspid valve, then if you square it, multiply by 4 and add the right atrial pressure, you will know what is the pulmonary artery pressure. And then because the right atrial pressure also increases, there is right to left shunting across the patent foramen ovum. Okay. So you see if you have a bidirectional shunt here at the PFO, a right to left to bidirectional shunt at the ductus arteriosus, then you have tricuspid regurgitation, bulging of the septum towards the left ventricle, increased right ventricular pressure. So all these are suggestive of pulmonary artery hypertension. Next, echocardiography has a very important role to rule out congenital cyanotic heart disease because sometimes it could be difficult clinically to differentiate between the two. And in those cases, echocardiography will help you to clinch a diagnosis. So a patient who has, for example, total anomalous pulmonary venous return can present exactly like PPHN. They can even have whiteout lung and they can have all features of PPHN, and it could be difficult to diagnose without having a proper echocardiography. Echocardiography also helps us to decide therapy and it also helps us to monitor the response to therapy. So echocardiography is important to diagnose pulmonary artery hypertension and rule out cyanotic heart disease. Now, these are some of the very simple videos I'm just showing you to have an idea. So you look when echo is done, you can see the four chambers of the heart. So this is the right atrium, this is the right ventricle, this is the left ventricle, and this is the left atrium. This one is a tricuspid valve, and this is the mitral valve. Look at the septum here. What is happening? The right ventricle appears to be more prominent, so there is some degree of RV dilatation, and the septum is bulging more towards the left side. So this indicates that the right ventricular pressure is higher than the left ventricular pressure. So here you could have a suspicion of pulmonary artery hypertension. Now, if you put color through it and you can measure, you can see there is tricuspid regurgitation on echocardiograph. That is, blood is flowing across the tricuspid valve from the right ventricle to the right atrium. And you can measure the TR, the tricuspid regurgitation velocity, and you can calculate the pulmonary artery hypertension. So here the gradient is approximately 77 millimeter of mercury, and if you can add the right atrial pressure, which is around 4 to 5 millimeter of mercury, so the pulmonary artery pressure here is around 80 millimeter of mercury. So normal pulmonary artery pressure should be less than 25 millimeter of mercury. So by echocardiography, you know exactly what is the pulmonary artery pressure if a TR jet is present. Then there are a lot of other parameters. I will not discuss all this because this is more for people who are doing super specialization. So this will skip. Now, let's come back to the case. So this case, the baby who had an FiO2 of 100% had oxygen index of 24. In X-ray, there was bilateral heterogeneous lung infiltrates and there was some hyperinflation and athleticis because it was a case of meconium aspiration syndrome. Echo showed evidence of pulmonary artery hypertension. There was tricuspid regurgitation, bidirectional flow across the duct and the PFO, and there was flattening of intraventricular septum. Now, this baby, when comes to our hospital, now starts to deteriorate. Baby has now worsening gas exchange. The perfusion becomes poor. So, how do we manage such a patient who has been diagnosed to have persistent pulmonary hypertension? and is in hypoxic respiratory failure. So if you look at the pathophysiology of hypoxic respiratory failure, it's basically a triad. Three things are affected at first. Number one is the lung disease. So if there is a secondary lung disease, secondary PPHN, because of pneumonia, because of HMV, because of meconium, then the lungs are affected. So there will be low lung volume in highly membrane disease, in diaphragmatic hernia, and the lung volume could be higher, or there could be areas of hyperinflation and regional gas trapping in meconium aspiration. So the lung is affected. Then what happens because the pulmonary vascular resistance is high because of pulmonary vascular disease. That means the pulmonary blood vessels have an increased vascular tone and reactivity. Then there could be situation where there's decreased vascular growth and hypertensive vascular remodeling, such as condition like diaphragmatic hernia, oligoamnias, and so on. Thirdly, because of increase in the pulmonary vascular resistance, what happened? The right ventricle pressure goes up. The right ventricle is pumping against a resistance, so there could be right ventricular failure. And gradually, as the disease progresses, because of septal deviation, because of hypoxemia, further there could be left ventricle dysfunction. So, in your management, you should have a strategy which you can manage the lung disease, you can manage the cardiac part, and you have to do some intervention to manage the pulmonary vascular resistance. Okay. So therefore, the management is four prongs. Number one is supportive care. So any kind of disorder in newborn baby, supportive care is very important, and this has to be taken care of, whether it's temperature, glucose, sugar, all those things. Third is here, second is that you have to maintain the lung disease. So you have to optimize the lung recruitment. So make sure the lung is neither hyperinflated nor it is low volume. So to optimize the lung recruitment, you have to have optimum ventilatory strategy that we're going to discuss. Then we should have intervention to decrease the pulmonary vascular resistance. So you need to use pulmonary vasodilators, and you should do some intervention to help the left ventricle and the right ventricle pump out properly. So you need to have a cardiovascular support. So these are the pillars of management in persistent pulmonary hypertension that presents with hypoxic respiratory failure. So supportive care, you maintain normothermia, optimize your ventilation. So here, the acceptable PaO2 is between 50 to 80 millimeter of mercury. This is quite acceptable. And you don't need to wash out the CO2. So you can accept permissible hypercarbia. So 40 to 60 millimeter of mercury of CO2 is acceptable if the pH is maintained. So maintain the blood pressure, tissue perforation. Correct acidosis if present. If there is acidosis, then you need to manage it by optimizing the perfusion, look for cause of acidosis, and that has to be managed. We should not alkalinize the baby routinely. That means we should not give soda bicarb because that is bad for the baby. It is found to increase the mortality, cause poor neurological outcome, and it can also lead to sensory neural deafness. So routine soda bicarb should not be given. It is harmful. Correct hypoglycemia, hypocalcemia, these are important. Calcium should be in the normal range because calcium is an important electrolyte required by the heart to pump properly. So these are small things which they matter. Then you should correct anemia, polycythemia if they are present because this will help the oxidation to be better. Now these babies have very labile oxidation, so you should handle them minimally. So if you have earmuffs, you can put them on earmuffs, cover their eyes, dim the light in the NICU, don't handle them too much. So these are things that are equally important. You need to routinely sedate these babies whom you're ventilating with PPHN, either with fentanyl or morphine. Paralysis is not recommended as a routine except in conditions where you are having difficulty in ventilating the babies, because paralysis with a muscle relaxant like vecuronium, pancuronium can lead to longer duration of ventilation and more issues in this such patient. And you optimize the nutritional support by giving parenteral nutrition in this patient. So these are the aspects of supportive care which needs to be taken care of. Then in ventilation, the principle is that you can accept some degree of relative hypoxemia. So the target oxidation should be between 93 to 97%. So this gives you a cushion that you do not fall much below 90, At the same time, you are also able to avoid hyperoxemia. A CO2, as I told you, between 45 to 60 is acceptable. So we accept hypercapnia here. But in these cases, the pH should be more than 7.2. And we try to optimize the tidal volume between 4 to 6 ml per kg. Now, these are the targets in ventilation which we try to achieve. In case you are requiring high ventilatory pressures to manage the patient with the PIP, peak inspiratory pressure of more than 25 to 28, IFR2, then it would be wise to switch to another mode of ventilation, which is high frequency ventilation. Then you optimize your PEEP in a way that you get good lung recruitment. So you can do an X-ray and see that the lungs are inflated between, say, 8 to 9 ribs. Okay, they are not hyperinflated, not beyond the 10th rib, and they are not low volume less than the 7th rib. So optimize the lung volume accordingly. So lung volume is important because if the lung volume is low, it will increase the peripheral vascular resistance because the alveoli will not be ventilated, they will be atelectatic. If the lung volume is high, it is hyperinflated, then the alveoli will press upon the vasculature. That will also increase the PVR, and further high lung volume can decrease the venous return and decrease the cardiac output.
I think we have lost Anu. Anu?
Audio is not working.
No, audio is not working. Even I think there is some network problem with Anu. Just calling.
I'll just give him a ring.
Hello. 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 Anu, can you hear me?
I think he has lost and he need to rejoin.
Hello, Anu. Lalan, can you join? You able to hear me?
Yeah, I can hear you, Surinder, but I think sir has called. Sir has called.
Oh,
I think for
Sir,
the
क्या हुआ?
students,
he is reconnecting. Light चली गई थी उसकी वाईफाई से.
अच्छा, reconnect कर रहा है, reconnect.
For the students, very thanks to you, Dr. Alok Bhandari, Mukesh, IAP New Delhi, NNF New Delhi, for organizing such an important program, lecture on persistent pulmonary hypertension, which troubles us so much. And I think he has so nicely, he's a very good teacher, I must say. My wife also says so because he's teaching. And he has actually started from the basic physiology, dwell nicely on it, so as for people to understand it. बच्चे अच्छी तरह से समझ सकें, जान सकें, धीरे धीरे करके समझाया है. और फिर सपोर्टिव मैनेजमेंट, रियल मैनेजमेंट कैसे कर सकते हैं, काफी अच्छी तरीके से बताया है. तो अनूप, हम आपकी तारीफ कर रहे थे कि फ्रॉम फिजियोलॉजी लेके मैनेजमेंट तक का, और लोगों को ये समझ पाना.
Diagnosis or echo finding also, na? Very nicely presented.
So sorry, I think the light.
So meanwhile, I will request the participant to put their question in the Q&A box. Okay, Anu,
so,
carry on, please carry on.
Okay. So I just explained to you about the lung recruitment, and it is very important to optimize the lung recruitment. So if you see a lung which is derecruited is like this. So this lung is going to have high pulmonary vascular resistance. You will have difficulty in oxygenating this lung. And a lung which is hyperinflated looks like this. Here also, when the lung is hyperinflated, what happens? It will press upon the pulmonary vasculature, and that will increase the pulmonary vascular resistance. So we don't want either of the situations. So we want a lung which is adequately inflated, not hyperinflated, not low volume lung. So that is very important. Now, in hypoxic respiratory failure, we talked about recruiting the lung. So there is a role of surfactant. This is one another drug which we have in our armamentarium. which can be given in certain conditions. So because this patient is hypoxemic, and there could be situations where surfactant can help you to improve the oxygenation. So if you have a setting where of diffuse alveolar disease, for example, there is surfactant deficiency, there is hyaline membrane disease, or what we call as surfactant deficiency disorder. So here there is deficiency of surfactant, the lung is low volume. So in these conditions, you should give surfactant if the FiO2 is more than 30% and if the picture is consistent with respiratory distress syndrome. So give surfactant in these conditions, and then you could recruit the lung with the strategy either with conventional ventilator, but if the pressure is high, you may need to go to high frequency ventilator. Again, if there is an airway disease, for example, there is a scenario of meconium aspiration syndrome. So here you could have two types of pulmonary disorder. One, it could be a predominantly lung which is atelectatic, which is collapsed. Okay, there are a lot of opacities. Other could be a lung which is hyperinflated. So if your lung is hyperinflated, well expanded, then you should be cautious and you should use low pressures, low P. Okay. If your lung is not well inflated and you find that predominantly the lung is such that the disease is diffuse and there are less signs of obstructions, so in these conditions also it is recommended that you give surfactant. Okay, it could be given either by bolus or by lavage. These are two modalities, but here also surfactant can help you. The ventilatory strategy in hyaline membrane disease is to keep higher PEEP. You give more PEEP so that maintain the functional residual capacity. But if you have a condition of meconium aspiration syndrome, then you keep the PEEP slightly on the lower side and you increase the E time, expression time also, so that the lung is filled, lung is emptying well. Okay, so increase the time constant, increase the E time, that's important. The third scenario could be a scenario of lung hypoplasia. So here the lung is hypoplastic, the lung is not well developed. So it could be a scenario of diaphragmatic hernia, or it could be a scenario of oligoamnias. It could be a scenario where there is leaking since second trimester, or it could be a scenario of renal disease where the child has not passed more urine and so the lung has not developed. So in these conditions, what will happen? The lung is hypoplastic and very fragile. So you have to be very cautious with the pressure. You have to give very low PEEP despite lung hypoplasia. The role of surfactant in these conditions is controversial. So you don't give routinely surfactant in diaphragmatic hernia or lung hypoplastic situation unless you have evidence of hyaline membrane disease. That is, the baby is premature and you see lung, there are some kind of evidence of HMD, so lungs are white out and so on. Otherwise, you avoid giving surfactant in these conditions. Okay. So apart from optimizing the ventilation, there are some targets which I talked to you. One is that you maintain the PaO2 between 50 to 80 millimeter of mercury. You can accept hypercarbia. So permissive hypercarbia is acceptable. So CO2 up to 40 to 60 millimeter of mercury is acceptable. Now, you usually start with conventional ventilator. So you set the PEEP, PEEP in such a way that you get optimized lung volume, not hyperinflated, not underinflated. Then if you have a setting where the lung volume is low, either there is diffuse alveolar disease, or there is meconium aspiration with heterogeneous kind of disorder, or there is lung hypoplasia, but the evidence of surfactant deficiency is still there, then you need to give a dose of surfactant to optimize the lung and you optimize the ventilation. Then if you are ventilating the baby on conventional ventilator and your PIPs are high, it is beyond 25, 28, your FiO2s are going beyond 60%, 70%. In these conditions, you have to take the patient on high frequency ventilator and carry on the rest of the principles of ventilation. Okay, so this is equally important. Okay. So we talked about two prongs, that one was supportive management and second was about the various ventilatory strategy. Third, we know that the heart is affected and there could be cardiac dysfunction, right ventricular dysfunction, left ventricle dysfunction. There could be hypotension, the blood pressure starts to go down, the RVO/LV can start failing. So you need to give some inotropes that can increase the cardiac contractibility, or you need to give some pressure agents, that means some agents that increase the blood pressure. Okay. The choice of inotropes again is very controversial. So we have a lot of inotropes with us. Dopamine and epinephrine are inotrope which most centers are comfortable to start as the first line inotrope. And these also increases the PVR, the pulmonary vascular resistance, more than the systemic vascular resistance. So if you start with dopamine or epinephrine, you should start with low dose epinephrine. Don't start with very high dose epinephrine. Dobutamine is not a good inotrope in persistent pulmonary hypertension because what happens, although it can improve the contractibility of the heart, but it decreases the systemic vascular resistance. So the blood pressure might not increase, but rather fall, and it may worsen your right to left shunt. Besides, dobutamine leads to increase in the heart rate. It has a very good chronotropic effect, and these can increase the myocardial demand. So most of the like new generation hemodynamic experts are now shifting to low dose epinephrine as the first line if there is cardiac dysfunction and hypertension. The new agent, I won't say new because this is almost since the last decade that a lot of case studies have been published in vasopressin. Vasopressin is basically a pressor agent, so it's a strong vasoconstrictor. It has no effect on the heart, but the beauty is that it increases the systemic vascular resistance, so improves the blood pressure, but it decreases the pulmonary vascular resistance. That means it will increase the pulmonary blood flow and result in better oxygenation. So this is what we want actually, increase in the SVR and decrease in the PVR, and this is exactly what vasopressin does. In addition, it leads to coronary and cerebral vasodilatation. So it improves the brain perfusion, it improves the heart perfusion, it improves the lung perfusion. Therefore, in many centers, people use vasopressin, low-dose vasopressin, as one of the first-line pressor agents when the cardiac functions are preserved. Then other agent which is popular is norepinephrine. This also has a similar action like vasopressin, which where it causes a decrease in the pulmonary vascular resistance and increase in the systemic vascular resistance. Okay, so these are how these inotropes act. Now, which inotrope to choose becomes a difficult question, and there also the scenario, the clinical scenario, and the echo findings can help you in choosing the inotropes in persistent pulmonary hypertension of newborn. So if you have a scenario where blood pressure is fine, cardiac function is fine, you don't need an.
So, so again, we lost Dr. No, I'm again calling him.
डॉक्टर ललन कोई हुआ कांटेक्ट उनके साथ?
मैं कर रहा हूँ सर। अनूप क्या हुआ, फिर लॉस हो गया? करो करो, अब वाइंड अप भी करना है ना आपको, थोड़ा सा INO भी बताओ और वो बता के, है ना? ठीक। ही इज ज्वाइनिंग सर, ही इज रीज्वाइनिंग।
ओके.
ठीक है. हेलो.
हाँ, आ जाओ आ जाओ.
हाँ, मैं तो हूँ सर. ये अनूप का है.
अनूप ज्वाइन कर रहा है, अनूप ज्वाइन कर रहा है, रीज्वाइनिंग। लाइन चली, लाइट वहां फिर डिस्टर्ब हो गया।
अबे भैया, अनूप का. आई हैव टू टेल हिम. इज इन द वेरी पॉश.
वेरी गुड, ही इज वेरी गुड टीचर, और बहुत अच्छे से धीरे धीरे सारा चीज ये पढ़ा रहा है ना? आई नो। कम बैक, वेलकम अनूप, शुरू करिए।
अनूप, तुम हमें घर पे
इन्वर्टर।
बुलाने वाले, हाउस वार्मिंग के लिए बुलाने वाले थे कई साल पहले. फिर हाउस वार्मिंग में नहीं बुलाया, इसलिए लाइट जा रही है बार बार.
यू आर म्यूटेड अनूप, यू आर म्यूटेड। अनूप आप म्यूटेड हो।
अभी वो डाल रहा है, पीपीटी डाल रहा है.
बेस्ट आप आ गए होटल?
आ गया, क्या करें? Okay, so I hope I'm audible now.
Yeah, now you are audible.
And I
Please.
hope the light, I mean, doesn't goes again because it takes time to reconnect. Okay, so we need to quickly finish now. It's already almost close to 1 hour. So the blood pressure, if it is normal, the cardiac function is normal. You don't need any kind of inotrope. You just need to maintain the oxygenation. If the oxygenation is not maintained, then you may need to give some pulmonary vasodilators. Now, there could be a condition where the blood pressure is low, but the cardiac function is normal. So here, since the cardiac function is normal, what you can do, you can start with a agent which improves the blood pressure predominantly. So it could be vasopressin, it could be norepinephrine or low-dose epinephrine. Okay, dopamine again is still used as first-line drug in many places because of experience of neurologists. But now the newer hemodynamic expert, they have stopped using dopamine because it increases the pulmonary vascular more than the SVR. If the blood pressure is normal, but the cardiac function is low, so this is a condition where there is role of milrinone and dobutamine because these inotropes, they do not increase the blood pressure, but they improve the cardiac function. There could be a scenario which is common in our country where the patient has come to you in a late stage, everything is low, the blood pressure is low, the output is low. These babies quickly deteriorate, and you may need to start multiple inotropes in this patient, and they should have standby therapies, ECMO, and so on, or you should refer them to centers if you are requiring multiple inotropes to manage this patient. So these are the various doses of inotropes. I'm not going to go through that. So this is what we just summed up so far in terms of management, that you do echocardiography, confirm, look at the cardiac functions, diagnose pulmonary artery hypertension, provide supportive care, optimize the lung, recruit the lung, give optimum PEEP, and you may need to give surfactant if there's low lung volume or if the disease is more like HMD or heterogeneous disorder. Normal blood pressure, good
Your
cardiac
slide is
function.
not moving. Your slide is not moving. Slide चल रहा है?
एक मिनट सर देखिए मूव कर रहा है, नहीं कर रहा है? Is it moving?
Now it's moving. अब आ रहा है.
Okay, ठीक है, ठीक है. Okay, so this is what we discussed so far, that you do echocardiography and you assess the pulmonary hypertension, look at the cardiac function. So you provide supportive care, recruit the lung with optimum PEEP, and you may need to give surfactant depending on what kind of disorder it is. Now, normal blood pressure, good cardiac functions, you just need to take care of oxygen, avoid hypoxia, hyperoxia, and you may need to give pulmonary vasodilators if the oxygen requirement is high. Normal blood pressure, but cardiac dysfunction. So here there's a role of milrinone, which is the inodilator, and it will improve the cardiac function. Condition where the blood pressure is low and the cardiac function is still preserved. So here you can choose an inotrope which will improve the blood pressure. So don't use dobutamine or milrinone. Here you have options of vasopressin, norepinephrine, or dopamine. Low blood pressure and cardiac function. This is the worst scenario where you have to use various kind of inotropes. And these are the patients who have high mortality, and they should be referred to centers which have nitric oxide or a backup ECMO. So far in our case, we have optimized the ventilation and perfusion. We have given surfactant. We are still on high frequency ventilator on high setting, and the oxygen index is high, it's around 25. So what is next to be done? Okay. So now we have to take care of the last limb and the important limb which is causing the pulmonary hypertension, the pulmonary vasculature. So you have to administer some drug or intervention to decrease the pulmonary vascular resistance. So the first choice is nitric oxide. So if, as you understand, I discuss where nitric oxide acts, it increases the cyclic GMP, leads to vasodilatation. So you can administer directly nitric oxide gas into the alveoli, and that will lead to vasodilatation. The next option is that to give some medication which inhibits the enzyme phosphodiesterase. So we give phosphodiesterase inhibitor so that the concentration of cyclic AMP or cyclic GMP is maintained. Sildenafil is one of the pulmonary vasodilators which inhibits the enzyme phosphodiesterase 5. Okay, so phosphodiesterase 5 enzyme is inhibited, and it leads to increase in the cyclic GMP, which causes vasodilatation. Milrinone is another medication which inhibits the enzyme phosphodiesterase 3, so it leads to increase in the cyclic AMP. And then we have bosentan, which acts at the endothelin receptors and inhibits the production of endothelin 1, endothelin A, which causes vasoconstriction. So these leads to vasodilatation. Then you have an option to give prostacyclins directly into the lung by nebulization, which will increase the adenyl cyclase enzyme and leads to increased cyclic AMP. So these are the options which you have, and these are the pathways where they act. Nitric oxide is the gold standard, pulmonary vasodilator. The beauty is that it acts in a matter of few seconds. It is a selective pulmonary vasodilator. It does not decrease the blood pressure, so there is no systemic action. And it is rapid, short-acting, and easy to deliver. Okay? So this has been found to be one of the most effective treatment of persistent pulmonary hypertension and has decreased the need for ECMO and has decreased mortality across the world. Now, to start nitric oxide, there is a rule of 20. So what does it mean, rule of 20? So the indication to start nitric oxide is when there is hypoxic respiratory failure with an OI of 20. So the baby should be term neonatal more than 34 weeks, less than 14 days of age. There should be echocardiographic evidence of pulmonary artery hypertension. The OI should be more than 20. And the starting dose is 20 parts per million. So this is what you are supposed to start in the dose. And when you start nitric oxide with 20 ppm, you expect the PO2 to increase by 20 millimeter of mercury, or there should be a decrease in OI by 20%. Okay, so therefore it is called rule of 20 of starting nitric oxide. Now, once the patient responds to nitric oxide, that means the OI comes down by 20% or PO2 increases by 20 millimeter of mercury. That means there is response to nitric oxide, and you should continue 20 ppm till the weaning criteria is met. So what is weaning criteria? For weaning criteria, remember rule of 60. So FiO2 is less than 60%, and the PaO2 is maintained more than 60 millimeter of mercury for 60 minutes. 60, 60, 60. So rule of 60 is the rule for weaning of nitric oxide. And you wean in the step of 5 till you come to 5 ppm. So from 20, you decrease to 15, 15 to 10, 10 to 5 every 6 hours. So 6 hours from 20 to 15. If FiO2 is less than 60 and PO2 is more than 60, then you come down further from 15 to 10, 10 to 5. After 5, you have to come down very slowly. 5 ppm, 4 ppm, 3 ppm, 2 ppm, 1 ppm, every 2 to 4 hours, because there are chances of rebound pulmonary hypertension. When you are weaning, at any case, if the FiO2 increases by 15%, you have to go back to starting nitric oxide. Okay. Now, you have to monitor the methemoglobin level because nitric oxide is ultimately degraded by hemoglobin and can lead to methemoglobinemia. So if methemoglobin level should be in the normal range, if it is between 5 to 10%, you decrease INO by 50%. If the methemoglobin level is more than 10%, you will have to stop nitric oxide. And monitor nitrogen dioxide levels, NO2 levels. This is displayed on the machine. So if it is getting more than 5 ppm, that means the nitric oxide is leaking down somewhere in the environment. This gas is toxic gas, so you have to discontinue nitric oxide for the safety of your nurses and healthcare providers. Okay. Now, the issue is nitric oxide is a costly gas, it is not available every year. So this is what we discussed. So persistent pulmonary hypertension, you did all these things, and still the oxygenation index is more than 25 or more than 20. Some units start at more than 15 if there is RV dysfunction. Okay. And there is a rule of 20 to start, 20 ppm, OI of 20, response by increases by 20 millimeter mercury. If there is response, then you start weaning. If the weaning criteria is met, which is rule of 60, FiO2 less than 0.6, PaO2 of 60 millimeter mercury for 60 minutes, wean in steps of 5 ppm every 4 to 6 hours till you reach 5 ppm. After 5 ppm, wean 1 ppm only to 2 to 4 hours. If there is a partial response or no response, make sure that your lung is well inflated, is optimized, and you may need to add on some other drugs. So either inotropes, or you may need to add on other pulmonary vasodilator like sildenafil or milrinone. So if there is improvement, you're happy, start weaning the same way. If there's no improvement, despite all these strategies, then you may need to consider the patient for ECMO. Now, nitric oxide is not available everywhere. So we are a resource poor country, and nitric oxide is a costly gas, although it is the gold standard. So ultimately, if it is not available and you are not able to shift the patient to a tertiary center with NO is available, then you should have at least some option to save the life of the baby. And there are some pulmonary vasculitis which still can provide you with some benefit. One of them is sildenafil, which I told you is phosphodiesterase 5 inhibitor. It can be given orally. The dose is 1 to 3 milligram per kg, 6 to 8 hourly, or you can give by continuous IV infusion with or without loading dose. So without loading dose, the dose is 0.03 milligram per kg per hour. So it is available in India both in oral and IV form. The issues with sildenafil is that the absorption is only 40%. It can lead to systemic hypotension. So this is one of the commonest reason why we had to stop sildenafil in our units. We don't know exactly the threshold to start, but most units start at OI of more than 15. It is effective in rebound hypertension when you are weaning off NO. So that condition could be start, or it could be start also as an adjuvant to NO. And the most important indication still in India is when nitric oxide is not available, you end up starting with at least sildenafil. Now, there are some of the issues with sildenafil that I told you already that can cause systemic hypotension, common side effect. It can lead to priapism. There's some controversy. It can lead to retinopathy of prematurity. So these are the various doses regime which we already discussed. Now, the next drug which we have is milrinol, and it is also a potent vasodilator, and it can augment the action of nitric oxide also. The most important indication of starting milrinol is when there is LV dysfunction along with hypoxic respiratory failure. So here you should start it. And the second indication is as an add-on drug to nitric oxide. So it can help you sometime. It decreases the oxidation index, and the dose is 0.33 to 1 mics per kg per hour infusion. Now, before you start milrinol, sometimes some of the experts they recommend that you give a small volume of 10 ml per kg of normal saline or Ingus lactate because you expect a fall of 8 to 10 millimeter of systolic blood pressure. So this is again phosphodiesterase 3 inhibitor. It can active. There are a lot of case reports and evidence about milrinol. So this we can just skip. The third drug, which can be given in bosantan. Bosantan is endothelin antagonist. So it decreases the production of endothelin 1, endothelin A, which is a vasoconstrictor, and it can lead to vasodilatation. Again, there are some randomized controlled trials, some studies which have shown the benefit of bosantan as an add-on drug to NO, and in settings where NO is not available. The only problem is that it has to be given orally. The dose is between 1 to 3 milligram per kg body weight. Issue is it can cause liver dysfunction, anemia, but there's no hypotension and there is no rebound pulmonary hypertension. The last drug which we have is prostacyclines. Now, we have this available in India. We market it sometime from the gray market. So this can be given by nebulization. You can connect it to the nebulizer with your ventilator circuit. And the dose is between 1 to 3 mics per kg every 2 to 4 hours. So prostacyclines directly act on the lung, and this can help you as an add-on drug with nitric oxide. In severe PPHN, if these strategies or if the patient is having very high ventilator requirement, hypoxic respiratory failure, another drug which has come up is L-prostadil. So this is PGE1. This drug is also a directly pulmonary vasodilator, and it also opens up the duct. Opening the duct is important because it helps to decrease the right ventricular dysfunction and provides relief to the right ventricle when the pulmonary pressures are very high. Last resort is ECMO. ECMO is extracorporeal membrane oxygenation. So with everything fails and the patient is still hypoxemic, patient is in refractory shock, then you do extracorporeal membrane oxygenation. So basically what you do, it's just like a bypass. So you take out blood from the venous circulation and externally outside the baby's body, you oxygenate the lung, you take out the CO2 from, you oxygenate the blood, you take out the CO2 from the blood, you warm it, you return it into the arterial system. So ultimately, the lung and heart both are bypassed when we do veno-arterial ECMO, and with this you can achieve oxygenation and perfusion of the baby. Okay. The indication for ECMO is conditions when the OI is more than 40, when the alveolar arterial differentiation is gradient is more than 60. There's refractory shock, acidosis, despite all your anatropes and everything for more than 2 to 4 hours. In these conditions, you should consult and the ECMO team and consider ECMO. The problem with ECMO is that this cannot be done in premature babies because this is very high risk of bleeding because of hypertension. So you can do it only when the gestation is more than 34 weeks. And there are other criteria which have to be fulfilled, like there should be no major ICH, it should be reversible disorder, there should be no coagulopathy, bleeding, and all those things should be also fulfilled. So coming back to our patient, we started INO, we added Milrinone, we did not need to ECMO. With INO, the patient responded, and we could extubate the baby. We stopped inotrope, weaned to CPAP, and the patient could be discharged on day 19 of life. Okay. So this is a very good picture from one of the very famous authors who is an expert in the world on PPHN, Lakshmi Narasimha. And you see he has summed up all in this picture that how do you manage this patient? So for supportive care, he has what he has done. He has patched the eye. He mentions about sedation, analgesia, avoid routine paralysis, maintain the nutrition, manage the glucose, manage the calcium. So these are components of supportive care. To in case of parenchymal lung disease, you give surfactant, you optimize the lung to ventilate with conventional ventilator. Now, if your PIP is going beyond 25, 28 centimeters of water, you consider high frequency ventilator. So this is when you should need to put on high frequency ventilator. Then if the OI is more than 20, you need to give nitric oxide to this patient. Now maintain a CO2 of 45 to 60 millimeter of mercury, PO2 of around 50 to 80 millimeter of mercury. Manage the blood pressure by giving inotropes. You need to give sometimes small volume. And these are the goals in terms of blood gases, which the pH should be more than 7.25, lactate should be less than 3 millimoles per liter. So this picture sums up all. So I'll just finish up with this slide. So what we learned today that persistent pulmonary hypertension is nothing but it's persistent fetal circulation where there's right to left shunt because of increased PVR and there's labile oxygenation. So therefore, it is called persistent pulmonary hypertension because the in utero state basically persists. The causes are could be maladaptation. Something has gone wrong during transition. So asphyxia, acidosis, hypoxemia, hypercarbia, all this can lead to maladaptation. It could be because of maldevelopment or hypoplasia of the lung, like diaphragmatic hernia, or it could be oligohydramnios, PPRM, or it could be secondary to some parenchymal disorders, or it could be idiopathic. Diagnosis, we have some clinical pointers based on history and examination, but it's ultimately established by echocardiography, and that is important because it also helps you to rule out congenital cyanotic heart disease. There are four prongs of management. Supportive care, we discussed about maintaining the temperature, looking at the blood sugar, calcium, nutrition, sedation, no routine paralysis, maintaining temperature. All these things are very important. Then we have to take care of the lungs, so optimize the ventilation. If required, give surfactant. You may need to ventilate conventionally or by high frequency ventilator, but make sure the lungs are equipped well. There's no underinflation or overinflation. Optimize perfusion by giving inotrope depending on how is the blood pressure and how is the cardiac functions. And you need to take care of the pulmonary vasculature. So use some pulmonary vasodilators. Gold standard is, of course, INO, but if it is not available, you can use sildenafil, and especially in resource poor setting. Sildenafil, I told you, is a phosphodiesterase 5 inhibitor. If there's LV dysfunction, you use Milrinone. If you are in setting where bosentan is available, you can use it orally. And prostaglandin analogs are another add-on therapies, which is available now in the gray market. And if these things fail in situation where there is refractory hypoxemia, the OI goes more than 40, there is persistence of shock and acidosis, which is persisting for more than 2 to 4 hours, then you need to think about sending the patient to a setting where ECMO is available. But again, it's something which is not available everywhere. The issue of feasibility, the cost, and optimization of outcome. So thank you so much, and sorry for the technical glitch which happened. And PPHN is something which we still really get scared in the middle of the night when a hypoxemic unit come to us. Thank you, sir. I will just conclude here.
So thank you, Dr. Arnav. It was excellent presentation.
आरोप हमें लग रहा है कि तुम मैच देख रहे थे बीच बीच में जाके यू जस्ट ट्राइंग टू सी मैच स्टार्ट हुआ है कि नहीं हुआ है ना
नहीं सर
ठीक है
नहीं मैच मैच नहीं
So,
देख रहा
but
था
it is very good. The slides were so clean, neat, and the management. In fact, you talked about the INO, the latest thing, Bosentan, Allopros. The things all were being covered together in the management of PPHN. So I hope the students have learned what they wanted to learn. And I think Dr. Anupam और अगर IAP Delhi इसका वीडियो शेयर करेंगे YouTube पे, so that will be a repository for all people everywhere. Such a Anup speaking it again and again will not be possible, but I suddenly feel this is a very good. Thank you, Anup. Thank you, Dr. Lalan.
Thank you, sir.
Thank
Thank
you.
you, sir.
Thank you,
Thank
Anup.
you.
It was a really excellent presentation, and you have discussed everything in detail.
There are some questions in the chat.
No, I think there is no question in the chat. So just to sum up, I think the early diagnosis, early recognition, and early initiation of treatment is key for the better outcome, right? And prevention should be on the upper hand, and if there is any risk factor, the prevention should be started in the labor room itself, right? Maintenance of hypothermia, judicious use of oxygen, and the judicious use of the ventilation. That is very, very important. And another thing that I would like to say here that this baby has long-term neurodevelopmental outcome, this delay also. So this baby needs to be followed up regularly. And Anup, how often do you follow up this baby? And how often this baby require echocardiography?
Sir, echocardiography, since most of us in the unit are now trained to do echocardiography, so one echocardiography is mandatory by the cardiologist. So, because even if we all are trained in functional echo, to make sure for such cases, a pediatric cardiologist must do an echo to rule out cyanotic congenital heart disease. Okay, that is one thing. Secondly,
No, I'm
if
talking about that once you have
follow-up.
diagnosed and no, once you have diagnosed this patient, manage the patient, then send this patient. So do you do this baby require echocardiography during the follow-up?
So after discharge, we don't need to do echocardiography because this is a disorder, which is acute disorder, and it settles down. As the pulmonary hypertension comes down, it is not something which persists. So you do need to do follow-up echo later on after discharge once patient is okay.
Okay. But the follow-up is required for this baby, right?
Yeah, for long-term neurodevelopment, it's very important that you follow up this baby at 3 months, 6 months, 9 months, 12 months, 15 months, 18 months, 2 years, and later on also. Because 25% of the babies who need ECMO or nitric oxide have developmental delays. So all the domains have to be followed up.
So you very rightly said that this echocardiography is the key for the diagnosis, gold standard for the diagnosis. But still in India, many centers don't have the facility of echo. In that situation, hyperoxia and hyperventilation tests may be used. Am I correct?
Yes, sir, because if we don't have any other option, then in the middle of the night, when there is no other option, that it could help you at least to rule out cyanotic heart disease. And that is important because if you're suspecting cyanotic heart disease, you'd like to start prostaglandin straight away. And if that is not a possibility, then you'd like to manage as PPHN. So if you're completely blinded, then in those situations, hyperoxia test will help you.
Right. So I think there is no question in the chat box. You have taught so well that everybody has learned and there is no questions. Sir, Anupam sir. Anupam sir. I think
there is not the answer is not.
Sir is not there. Surinder? So thank you once again.
Thank you, sir. Thank you, everyone. Thank you so much, sir.
Thanks everyone. अभी भी 12 पार्टिसिपेंट है सुन रहे हैं. थैंक यू ऑल एंड आई होप कि ये वीडियो जो है सो यूट्यूब पर डाउनलोड हो जाए, अपलोड हो जाएगा एंड पीपल विल बी बेनिफिटेड. थैंक यू.